Okay, in our video series of ECG interpretation made easy, in this video we are going to talk about a ventricular rhythm called as ventricular tachycardia. Remember, ventricular rhythms include premature ventricular complexes, ventricular tachycardia, ventricular fibrillation. In this video, we are going to talk about ventricular tachycardia. In my previous video, I have talked about premature ventricular complex in detail. Now, normally SA node produces electrical currents, and those electrical currents cause depolarization of the atria. These electrical currents travel through internodal pathways to the AV node. AV node sends these signals through the bundle branches to Purkinje fiber, and Purkinje fibers cause contraction of the ventricles. So, SA node controls the electrical activity of the heart, that is called as a sinus rhythm run by SA node. Now, what if the SA node fails to produce electrical currents? If SA node fails to produce electrical current, AV node takes charge of the heart electrical rhythm. AV node takes control. AV nodes produces electrical currents and runs the rhythms of the heart in the absence of SA node. What if AV node also fails to produce electrical rhythm? In such case, Purkinje fiber takes control of the heart and produces electrical rhythms that cause contraction of the heart muscles. This is such a beautiful system. If one thing fails, second thing takes over. If second thing fails, the third thing takes over. And what if the Purkinje fibers fail to produce the electrical currents? In such case, ventricles start producing electrical currents, and those ventricular muscles cause contraction of the heart. But these contractions by ventricular muscles are not normal. These contractions, these electrical signals from the heart muscles are not normal. Failure of the atria and AV junction to initiate the electrical rhythm of the heart. When the SA node fails, when the AV node fails, when even the Purkinje fiber fails, in such case the ventricular muscles take control of the electrical activity of the heart. That is called as a ventricular rhythm, a rhythm generated by the ventricular muscles, that is not a sinus rhythm. Now, coming to the morphology of ventricular rhythms produce wide, bizarre looking waves. They produce wide waves because the speed of SA node to depolarize is rapid. The speed of ventricular muscles to depolarize is slow. Therefore, there is a huge interval during which the depolarization takes place, and the wave that appears on the ECG is wide. The T waves are opposite in the direction of R wave. Now, if this is the R wave of the QRS, the T wave will be in the opposite direction. That is the classical feature of a ventricular rhythm. P waves possibly might not be visible. P waves might be present, but since these waves are so wide that they are actually hiding the P waves, the QRS interval is greater than 0.12 seconds. Since I said that these waves are wide, so when you calculate the width of the QRS complexes, the QRS complex width will be more than 3 boxes, and that is a wide QRS. So the QRS interval will be greater than 0.12 seconds. Each small box is equal to 0.04 seconds. 0.04 multiplied by 3 is 0.12 seconds. So these are greater than 3 small boxes. Now, how do you measure QRS complexes in such ventricular rhythms? There might be more wide QRS complexes in one lead, and there might be less wide QRS complexes in the other lead. So what you do is, when you are interpreting the ECG, you always choose the widest QRS that is present in any lead. Now, to understand ventricular tachycardia, you need to have some knowledge of premature ventricular complex. Basically, what happens in premature ventricular complex is that SA node is normally causing the contraction of the atria and ventricles. There are normal QRS complexes, normal sinus beats going on in ECG, and all of a sudden an ectopic focus present in the ventricle starts producing current, and that current interrupts the normal sinus activity by the SA node. The SA node is pacing the heart and causing the normal sinus node beats. But in between those sinus node beats, you will see an abnormal wave due to this ectopic focus. That ectopic focus interrupts the normal activity of the SA node. That is called as a premature ventricular complex. So this is a picture showing a premature ventricular complex. These are the normal sinus beats that are going on, and in between those sinus beats there is a huge bizarre wide wave. That huge bizarre wide wave is the premature ventricular complex that is interrupting the normal sinus beating of the heart. That is called as a premature ventricular complex, also called as PVC. Now, when you understand premature ventricular complex, it's very easy for you to understand ventricular tachycardia. What happens in ventricular tachycardia is 3 or more premature ventricular contractions occur in a row. That is called as a ventricular tachycardia. Now, ventricular tachycardia can be sustained where these premature ventricular contractions last for greater than 30 seconds. Now this is an ECG showing a normal sinus beat, another normal sinus beat, and all of a sudden a premature ventricular complex appears, and then the premature ventricular complex result in ventricular tachycardia. More than 3 premature ventricular contractions occur in a row, and that is called as a ventricular tachycardia, and that is called as a sustained VT when these premature ventricular contractions occur for greater than 30 seconds on an ECG. They are called as non-sustained when these premature ventricular contractions last for less than 30 seconds. That is called as a non-sustained ventricular tachycardia. Now in this ECG, if you can see, this is a PQRS T wave, a normal sinus beat, another normal sinus beat, and now the premature ventricular contractions start to appear. Another premature ventricular contraction, another PVC, another PVC. But then this sequence of PVC ends over here, and then sinus beats start to appear, another sinus beat starts to appear, and after that then again there is a PVC, another PVC. Now the PVCs are there, but the PVCs are not lasting for more than 30 seconds. That is called as a non-sustained ventricular tachycardia, in which there is a ventricular tachycardia for less than 30 seconds, and it is interrupted by the normal sinus beats. That is a non-sustained ventricular tachycardia that lasts for less than 30 seconds. Now, in a patient with ventricular tachycardia can occur with or without pulses. Now, this is an important point to differentiate it from ventricular fibrillation. In ventricular fibrillation, whenever the patient gets ventricular fibrillation, patient get pulseless, patient gets unconscious. While in ventricular tachycardia, patient can be conscious, patient can have pulses even in the presence of ventricular tachycardia. And even in the presence of ventricular tachycardia, patients can sometimes have no pulse. That is called as a pulseless ventricular tachycardia. A ventricular tachycardia where there is no pulse, where the ventricles are contracting such haphazardly that they are not causing contractions of the ventricles properly, and blood is not pumping out from the heart. That is called as a pulseless VT, where the ventricles are literally seizing with currents like this. The ventricles are having a seizure and they are not actually contracting. Therefore, there is no pulse. That is called as a pulseless VT. Pulseless VT is an emergency. It needs shock. You need to defib the patient. In pulseful VT, in which there is pulse, patient can be conscious, patient can have pulse, and there is still ventricular tachycardia going on. And you can treat this type of ventricular tachycardia with medications. There is progressive loss of cardiac output. Now, if a patient develops ventricular tachycardia, patient can have pulses initially, but later on that patient can convert into ventricular fibrillation, or that patient can develop pulseless ventricular tachycardia. It can very quickly deteriorate to ventricular fibrillation and even asystole, where there is flat line. Now, what are the causes of ventricular tachycardia? Ventricular tachycardia can occur due to re-entry circuit, increased automaticity after depolarization. In re-entry circuit, what happens is that these ectopic foci are producing electrical currents, and those electrical currents travel within the ventricles and they re-enter the ectopic foci and they re-stimulate the ectopic foci to produce more currents. A positive feedback loop is formed. That is called as a re-entry circuit. Increased automaticity, heart muscles when it gets damaged after a myocardial infarction, heart muscle when it gets damaged due to chronic congestive failure, heart muscles when it gets damaged, when it gets abnormal after pathological hypertrophies. it can develop increased automaticity where there is increased production of electrical currents, and those electrical currents fight with the SA node and they cause abnormal rhythms of the heart and make the ventricle seize like this. After depolarization, normally when the ventricles depolarize, there is a wave and then they repolarize, and during the repolarization period there is a period that is called as a refractory period. In that refractory period, those ventricles cannot depolarize again. That time space, that break is important for the electrolytes to rearrange themselves inside and outside the cells. But what happens in after depolarization is that the ventricles just got depolarized and they were about to repolarize again, but before getting properly repolarized, they again get depolarized. So that is actually a quick excitation. Even before one depolarization has ended, another depolarization took place. That is called as an after depolarization, and that results in arrhythmias in ventricles that causes ventricular rhythms, ventricular tachycardias. Now ventricular tachycardias on ECG can appear like this. They can also appear on ECG like this. They can have a morphology like this. Their morphology can also appear like this. So these are all different types of ventricular tachycardias that can appear on ECG. Now coming to the characteristics of ventricular tachycardia. In the ventricular tachycardia, the heart rate is greater than 100. Greater than 100 is a tachycardia. 100 to 150 beats per minute is actually called as a slow ventricular tachycardia, because normally the ventricular tachycardias are so rapid that they are found around 150 to 300 beats per minute. The heart is seizing, the heart is at a very fast pace and it is not producing cardiac output sometimes. That is called as a pulseless VT. The regularity is regular. The P waves are absent, because the ventricles are now in charge of the heart and they are actually causing the heart to seize. That therefore you won't see any P waves, because these wide QRS complexes are going on in so much speed that they might be even obscuring the P waves. The P to QRS ratio is not applicable because we don't have the P waves. We only have the QRS complexes, the wide QRS complexes. The PR interval, we cannot calculate any PR interval because we do not have the P waves. The QRS complexes are wide. They are greater than 3 small boxes. They are greater than 0.12 seconds. So these are all the characteristics of ventricular tachycardia. Now let's solve some ECGs. This is an ECG showing ventricular tachycardia. Now remember, this is a monomorphic ventricular tachycardia. This thing is an important thing to remember. There are actually multiple foci in the heart that are producing these electrical currents in the ventricles, but when one focus is dominant over the other foci of the ventricles, when one focus of electrical rhythm is dominant over the others, it will produce a ventricular tachycardia that looks the same. All waves are similar to each other. It means that there is one focus present in the ventricles that is dominant over the other foci. There are many other foci that are producing electrical currents, but one focus is the alpha male in that. The one focus is dominant over others. Therefore, it is producing a monomorphic ventricular tachycardia. A monomorphic ventricular tachycardia actually indicates that the one focus is dominant over the other ones. Now in the next video, when we'll talk about polymorphic ventricular tachycardia, there will be multiple foci that will be producing electrical currents, and the ECG rhythm will show a mixture of all of those rhythms. That is called as a polymorphic ventricular tachycardia. Now, heart rate. If we calculate the atrial heart rate, we cannot calculate the atrial heart rate. We are unable to obtain the atrial heart rate because there are no P waves. If you look at the ventricular rate, in ventricular rate, one thing that you can do is that you can take the lower and the sharp point and you calculate the number of large boxes in between. The good thing would be that you calculate it by 6-second method. Now, if we calculate it by 6-second method, I have talked about 6-second method heart rate calculation in detail in my video on rhythm determination. I have actually talked about regularity, P waves, PR interval, QRS complex in detail in that video. The link of that video is given in the description. Now, in 6-second method, basically what we do is that we count 30 large boxes. We can count 30 large boxes. Since we have a short strip over here, we will count 15 large boxes, and in those 15 large boxes, we will count the number of QRS complexes that are present. Then since we have taken 15 large boxes, we will multiply the number of QRS complexes by 2. So it shows the number of QRS complexes in 30 large boxes. Now the number of QRS complexes present in 30 large boxes multiplied by 10 is equal to heart rate. That is the 6-second method. If you want to go into details, check out my video on rhythm determination. Now 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 15 large boxes. The number of QRS complexes present in the 15 large boxes is equal to 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 multiplied by 2 because we need QRS complexes in 30 large boxes. 10 multiplied by 2 is 20. Now answer 20 QRS complexes are present in 30 large boxes. The answer is multiplied by 10 is equal to heart rate. 20 multiplied by 10 is 200 beats per minute. 200 beats per minute is the ventricular rate in this rhythm by 6-second method. Regularity is regular. P waves are absent. PR interval we cannot calculate. We do not have the P waves. Now let's look at the QRS complexes. The QRS complexes are actually having 1, 2, 3, 3.5. So there are basically more than 3 small boxes present. That is a wide QRS complex. 3 or more than 3 small boxes in a QRS complex is a wide QRS complex. Each small box is equal to 0.04. So almost 3 multiplied by 0.04 is 0.12 to 0.16 second is the QRS width. Interpretation. This is a sustained ventricular tachycardia. Sustained because we do not see any sinus rhythm in it. It is a sustained VT. Now what you should do is pause the video, take a piece of paper, a pencil and solve this ECG. Solve these ECGs yourself. Till the time you don't solve these yourselves, you won't remember anything. This is another picture of ventricular tachycardia. Now going to the answer of this ECG. Let's calculate the heart rate. Let's apply the 6-second method. We'll calculate 15 boxes since we have a short strip. We do not have 30 boxes, and then we'll multiply the answer by 2 so that we get the QRS complexes in 30 large boxes. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 15 large boxes. In the 15 large boxes, we have 1, 2, 3, 4, 5, 6. 6 QRS complexes in 15. 12 QRS complexes in 30. 12 multiplied by 10 is 120 beats per minute. So we have ventricular rate of 120 beats per minute in this ECG. Atrial rate we are unable to obtain since we have no P waves. The rate is regular. The P waves are absent. PR interval is not there. Let's look at the QRS complexes. So we have 1, 2, 3, 4, almost 4 small boxes. So even we have more than 3 small boxes. That is a wide QRS complex. Coming to the interpretation, this is a sustained slow ventricular tachycardia. As I said, from 100 to 150, that is a slow VT. Although it's a rapid rate, but still according to VT, it's a slow VT. Pause the video, solve this ECG yourself. This is an ECG of ventricular tachycardia. Now coming to the answers, let's calculate the rate, atrial rate unable to obtain. Let's calculate 15 boxes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. In 15 large boxes, we have 1, 2, 3, 4, 5, 6, 7. 7 QRS complexes in 15 large boxes, 14 QRS complexes in 30 large boxes. So 14 multiplied by 10 is equal to 140. So the ventricular rate is 140 by 6-second method. Regularity is regular. The P waves are absent. PR interval cannot be determined. Now let's look at the QRS complexes. The QRS complexes are huge over here. We'll 1, 2, 3, 4, 5. 5 small boxes. 5 small boxes. 5 multiplied by 0.04 is 0.20 seconds. Interpretation is sustained ventricular tachycardia, which is slow because the heart rate is 140. In this ECG, you can see this is the sinus rhythm going on, normal P wave, QRS, narrow QRS complexes, less than 3 small boxes QRS complexes. These are normal QRS complexes. It means that the SA node is running the heart rate. There are P waves and QRS complexes are present. But then there is a premature ventricular complex, a PVC is present, and that PVC puts the heart into a ventricular tachycardia, and that is a sustained VT, because after this we do not see any normal sinus beat. Now let's calculate the rate in this. I have already calculated the rate. It's 120 beats per minute. The regularity is irregular, since look at the RR interval over here, and let's look at the RR interval over here. So this PVC is actually causing irregularity. In one rhythm we have an irregular rate. P waves are present till here. After that, P waves are absent. So P waves are present plus merit to the QRS complex until the patient developed ventricular tachycardia. Let's look at the PR interval. PR interval, we have 1, 2, 3, 4. 4 small boxes. 4 small boxes multiplied by 0.04 is 0.16 seconds. Then they are absent because patient developed VT. So we have to comment on both sides, the normal sinus beats as well as the ventricular tachycardia side. Let's look at the QRS complexes. We'll take the widest QRS complex. The widest QRS complex is 2 small boxes wide, that is 0.08 seconds. That's normal. Less than 3 small boxes, that's a sinus beat. Until the patient developed premature ventricular contraction and VT. The premature ventricular contraction is having 1, 2, 3 small boxes, and 3 or more than 3 small boxes wide QRS is a wide QRS. Interpretation of this ECG is that the patient had sinus rhythm, then that patient developed PVC. After the PVC, patient went into a sustained ventricular tachycardia. This is so easy. Now coming to the management of ventricular tachycardia. Management of ventricular tachycardia is very important, as you commonly see ventricular tachycardia in the wards in many patients. Now, as I said, patient with ventricular tachycardia can be stable. Patient can have pulses with ventricular tachycardia. Patient can be conscious with ventricular tachycardia. While in ventricular fibrillation, patient very quickly get unconscious. Patient very quickly loses the pulses. While in ventricular tachycardia, patient can be stable. But remember, a stable patient with ventricular tachycardia will very quickly decompensate if you don't treat it, if you don't manage it. So a patient with ventricular tachycardia can develop pulseless VT and even go into ventricular fibrillation, which is lethal. Now, if the patient is stable, you can do pharmacologic intervention. You can treat the patient with medicine. But if the patient is unstable, if the patient is having pulseless VT where there are no pulses, or if the patient is losing pulses, patient is losing blood pressure, and the patient is getting unstable, the next thing you have to do is you have to shock the patient. If the patient is unstable, shock the patient. You do DC cardioversion, you shock the patient and you revert the rhythm straight away. Now, if the patient is unstable and patient's ECG shows ventricular tachycardia, the next thing you have to do is that you have to start CPR straight away. Till the time the defibrillator is available, you have to follow the ACLS protocol. I'll zoom in on this. The first thing that you have to do, till the time the nurse brings the defibrillator or the doctor brings the defibrillator, you have to start CPR. You start doing CPR. You initiate the ACLS protocols. I have talked about cardiac arrest protocols in detail in my video on cardiac arrest management. The link of that video is in the description. You start CPR, you give oxygen, you attach monitor, you bring the defibrillator, and if the patient is having ventricular tachycardia, a pulseless ventricular tachycardia where there is no pulse, you straight away shock the patient. You give shock. Then after that, you recontinue this, you restart the CPR. You restart the CPR and then you reassess the rhythm, that whether the rhythm again is shockable or not, whether the patient is still having ventricular tachycardia or not, whether the patient has developed ventricular fibrillation. If there is ventricular tachycardia, if there is ventricular fibrillation, that is a shockable rhythm. If the patient develops asystole, a flat line, or pulseless electrical activity, in that situation you cannot give shocks. In ventricular fibrillation or pulseless VT, you can give shock. That is a shockable rhythm. So V.FIB, V.Tach, you shock. Now, if it is a shockable rhythm, you again give shock to the patient. You again defibrillate the patient. And then you continue CPR, and with that you give epinephrine 1 mg every 3 to 5 minutes. And then again you check the rhythm, that whether the rhythm is shockable or not. If there is V.FIB, V.Tach, you again give the shock. And after this shock, you give amiodarone or lidocaine. I'll talk about the amiodarone and lidocaine in a while. If the rhythm is not shockable, you move on to the other side of ACLS side. Another side of the ACLS where the rhythm is non-shockable. In the non-shockable rhythms, the only thing that you can do is that you can give CPR and you can give epinephrine. There is nothing else that you can do in the non-shockable side. In the shockable side, you shock, you check, you continue CPR, you give epinephrine, you check the rhythms, you give continue CPR, you check the rhythm. If it is still shockable, you again shock the patient, and then you give amiodarone or lidocaine. So this is the ACLS protocol. I'll post this chart on my Facebook page so that you can easily download it. Now coming to the doses, I'll read these things out because these things are written very small. Epinephrine is 1 mg every 3 to 5 minutes. Amiodarone is first dose is 300 mg bolus, second dose is 150 mg. Or if you are not giving amiodarone, you can give lidocaine IV. First dose 1 to 1.5 mg per kg. Second dose 0.5 to 0.75 mg per kg. You look for the reversible causes. In the causes of patient developing ventricular tachycardia, you look for hypovolemia, hypoxia, you check for acidosis, hydrogen ion, you send ABGs, hypovolemia, hypokalemia, hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, thrombosis, coronary artery thrombosis, pulmonary thrombosis. So these are all the H, 4H and 4Ts that you have to check while giving the CPR. And if the patient is stable, if the patient is conscious, and if the patient is having pulses, in such situation you can go for pharmacological cardioversion. You don't need to give shocks to the patient. In such case, you give IV amiodarone 150 mg IV over 10 minutes followed by 1 mg per minute for the next 6 hours. Or you can give IV lidocaine 1 to 1.5 mg per kg, typically 75 to 100 mg at the rate of 25 to 50 mg per minute. Or you can give IV procainamide if amiodarone and lidocaine are not available, 20 to 50 mg per minute until arrhythmia terminates. The maximum dose is 15 to 17 mg per kg. Now, what if the patient gets the pharmacological treatment but still the rhythm is not reverted? In such patients, you go for defibrillation. You tell the patient that we are trying to abort the rhythm, that abnormal rhythm can be lethal. But with the drugs, we have failed to abort the rhythm. Now we need to cardiovert the patient. In a conscious patient, remember, always sedate the patient first, then give shocks. It's criminal to give shocks to a conscious person. You first sedate the patient, you either give midazolam, you sedate the patient for some time, and then you cardiovert the patient in a stable patient with VT that is unresponsive to the pharmacologic interventions. Other than that, if the patient is developing non-sustained VTs frequently, in such patients, you put implantable cardioverter defibrillator. What implantable cardioverter defibrillator does is that it detects whenever the heart develops abnormal ventricular contractions or abnormal ventricular rhythms, and it bombards these abnormal ventricular rhythms with the signals and currents and stops them, suppresses them. It is always present. It is a device that is present with the patient's heart all the time, and it detects the abnormal rhythm, it bombards the abnormal rhythms, and it controls the abnormal rhythms so that the patient does not develop VT, sustained VT. General measures include correction of electrolytes. Remember, in all arrhythmias, always correct electrolytes. The very basic thing is to correct the electrolytes, because many times these electrolyte abnormalities are causing arrhythmias and you are looking for the big causes while you are missing out the very basic things. Hypoxia should be corrected, acidosis should be corrected, hypomagnesemia, hypokalemia should be corrected. Beta blocker are effective in prevention of a ventricular tachycardia. If the patient is developing non-sustained VT, beta blockers can be given to control the ventricular tachycardias. If you liked my video, please click on the subscribe button and check out my other videos on ventricular fibrillation and polymorphic ventricular tachycardia, premature ventricular complexes. The link of those videos are given in the description below. In this video, we talked about what is ventricular rhythm, what is the morphology of ventricular rhythm, what are premature ventricular complexes. 3 or more premature ventricular complexes in a row is called as ventricular tachycardia. How can ventricular tachycardia present, the causes, the different morphologies, characteristics of ventricular tachycardia, and the management of ventricular tachycardia. the CPR protocol, the ACLS protocol in an unstable patient with VT. The general management measures. If you liked my video, please click on the subscribe button and check out my other videos on ECG interpretation made easy video series. The link of that video is given in the description below. Thank you very much. And if you want to support this channel, you can support us on Buy Me a Coffee. The link of that is also given in the description. Thank you very much.